Welcome to the American Shoulder and Elbow Surgeons podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, and today I'm joined by my guest co-host, Dr. Jon Barlow, a shoulder and elbow surgeon at the Mayo Clinic in Minnesota. John, how are you?
Great. Happy to be here.
Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, the Mayo Clinic, or the institutions of any of our guests. Okay, so today we have the supreme good fortune to be in the city of Munich, Germany, to be joined by Dr. Patric Raiss. We spent 2 days with him in the operating room, and he's been a very gracious host and has shown us around Munich, and we've had a phenomenal visit. So Patric, welcome to the podcast.
Peter, John, thank you. I'm really happy to be here.
So we've learned a ton from you, and I wanted to start. You've made a number of really important contributions to our literature on the arthroplasty side. Recently, I think some of the most interesting things have been about short stems and stem size. We watched you do a stemless arthroplasty. I want you to talk for just a minute about your journey. You trained with Jill, and you've journeyed kind of through stem lengths to where you are right now. Talk to us a little bit about that journey for you, and what do you think ideally we look for when we look at the humeral fixation of the humeral component in shoulder arthroplasty?
Thanks, Peter. So, I started in 2006 my residency in the shoulder department of the University of Heidelberg together with a guy called Markus Löw. He published a lot about arthroplasty. And at this time, we started with classic standard length cemented stems for anatomic arthroplasty as well for reverse arthroplasty. And we did a lot of humeral head resurfacings at that time. The outcomes were not always good. And then there was some point like a transition going to uncemented stems and to shorter stems. So at this time, we worked pretty close with the Tournier company, and there was this transition from standard length stems to these kind of short stems. And we were pretty enthusiastic by implanting them because, it was much more easy without going for cementing of the stem. It was not so time consuming, and so it was a great experience. But with the first generation of these short stems, we found a high rate of stress shielding, and also in some studies we found loosening. And this is something that never happened with our classic cemented stems. And we published a series of, I think it was 600 cases or so in the JBJS American in 2014. And this never happened before. So there was some modifications done with porous coating and so on these short stem devices. And then it became better. However, we found that there's still a significant amount of stress shielding around these short stem curved components. And this was something that worried us. Also, it seems to be just a radiographic phenomenon. However, it is there. And at the beginning of, for example, reverse shoulder arthroplasty, we also said for scapular notching, it's just a radiographic observation. But, with more long-term follow-ups, we see that it also can become a clinical problem. So this is actually something that is not completely solved. However, for some short stems, we tried to define like a cutoff how thick we should go with our uncemented stems in order to have a good stability and to avoid stress shielding.
One of the questions I want to ask as a follow-up about that is about reverse. We're in the United States kind of on the precipice of stemless reverse. There's obviously an IDE that's been done. There's other IDEs that are about to be started. It is expected within the next several years those will be on the market in the United States. You're in a privileged position here in Europe of having had stemless reverse components on the market, but I notice you're not using them. So tell me, how does fixation differ for you for a reverse on the humeral component, and why is stemless maybe a good or a bad idea in that situation?
So first, we have a big and long experience, actually since 15 years in Europe and especially in Germany with canal sparing anatomic replacements. So we are using these components since more than a decade, and actually there's not a big problem at all. Even in older patients, osteoporotic patients with necrosis, I still use these kind of components. And as I told you, I don't even have a stem for anatomic arthroplasty in my clinic. So that seems to be not a problem. However, for reverse arthroplasty, the forces are completely different. You have compression forces and so on. And the reason why I am not using it's actually, but I'm completely, it's just my opinion, is that there's not the correct design for stemless reverse arthroplasty on the market right now. I'm sure that it will come, and there will be one or two or several, However, with the components actually on the market, I'm not really convinced to go to an stemless reverse arthroplasty.
Thoughts about advantages of that stemless in the anatomic perspective? You talked about stress shielding. I think there's some indication of some stress shielding under the stemless components too, but we've certainly seen in the United States some of these large diameter short stems and then periprosthetic fractures and otherwise. Is that something you guys have seen with the expanded use of short stems?
Yeah, I mean, I used these short stems for probably 5 years in a high volume, and it's always a dilemma, because on the one side you don't want to have subsidence or loosening, and on the other hand you don't want to have stress shielding. So of course, if you're in doubt, usually you go for one size thicker, but this may lead to stress shielding in the future. So our recommendation in one of our papers describing this phenomenon was to go for a cemented technique. However, if you're used to do uncemented stems, it's hard for you to switch back to cement. So this is this kind of dilemma where I think a lot of surgeons are in between, and I would rather go for one size thicker than to have the risk for subsidence or loosening with a short stem.
That's great. And then the other question that I wonder about is the other advantage of the long stems or conventional length stems is we could get the alignment perfect with that. And then with the short stems, we saw some alignment issues, and I think we're seeing more of that with the stemless. Any thoughts about your personal tips or tricks to get the alignment and height just right?
Yeah, I mean, that's really a good point, and we also published the results of malalignment of short stems. And we are talking about the inclination on the glenoid side, we are talking about neck shaft angles 155, 135. But what we found interestingly is that by malalignment, your neck shaft angle may change completely. And surprisingly, exactly at the same time when we did this study together with Gilles Walsh, and I think it was George as well, the group with Alex Lederman and Philippe Collet did exactly the same thing, and both papers were published more or less at the same time, and we didn't know actually. So, and what we found was that there's a huge variation, up to 20 degrees in neck shaft angle, that you can achieve by malalignment. So we are talking about 135, 155 or 145, but at the end you implant a component with 145 neck shaft angle and you end up with 165. I mean, this is hard to explain. So my tips and tricks, and there was a study going on in a cadaveric situation using longer broaches in order to have a good alignment. However, also this group found malalignment. So it's pretty hard. I think it's depending on the system you use. If it's a curved stem, if it's a straight stem. What I did when I'm using a short stem, I try to be as central in the canal as possible. I look at my planning. I do almost of all of my cases 3D planning pre-op, also for the humeral side, and I try to respect what I've planned, and I try to be as centric as possible. So I go in with a long like a K-wire, like a rod, metallic rod, in order to find the canal, to have an idea about that, and I try to align this.
That's great. And then one more, and then Peter, you can ask some questions. I'm just so curious about a lot of these things. One of the things you talked about some was subsidence, and we used to think humeral loosening was almost non-existent in shoulder arthroplasty. Can you give us a sense? You looked at all these x-rays. Can humeral stems subside and then ingrow? Do you think that's something that can happen? And what are some tips to tell? We think of a stem that's moved as a stem that's loose, but can you give us tips and tricks to identify stems that have moved and ingrown versus stems that have just become loose?
I mean, usually stems that become loose, you see it in the X-rays because there's something around the component, completely around it. When we analyzed this kind of subsidence in this ascent flex prosthesis, which is an onlay prosthesis from the Tournier at this time, what we saw was that the metallic tray that was perfectly onlay onto the humeral cut, subsided after time. So it was pretty easy to detect if a component subsided, and this happened in more than 10% of cases, if I remember correctly. So, however, they were not loose, so they just subsided over time due to the compression forces, and then they found their stability, and there was ingrowth, so there was no loosening. However, if there's loosening, the component will shift. If it's completely loosened, it will shift over time and lose its position.
The last thing I want to chat with you about before we move on from arthroplasty is, we watched you do an anatomic arthroplasty with obviously a beautiful result, and one of the things that I thought you were very, very careful about was pressurization on the glenoid side. I know you've done some work in this area. Tell us about how you approach that.
So, there are several factors for the longevity of our anatomic replacements, and I think if you look at I would say some bad results from the past, everything was mixed, different kind of pathologies, patients with rotator cuff tears, really B2 glenoids and so on. And maybe this is one of the reasons why we have so high loosening rates. However, if I go for an anatomic replacement, I want to have a patient with a perfect cuff, with a perfect bone, then I decide to go for anatomic. And I think one crucial step is, as you mentioned, Peter, to have the correct technique. We know from former studies, from former surgical techniques, they make a curettage of the glenoid walls. They took out all of the bone in order to have more cement in the glenoid wall, and so on. So this changed over time, and I'm trained in the University Clinic of Heidelberg, which has a big experience in studies with cementing techniques. And what we found is that by using a jet lavage is pretty beneficial to have a better cement penetration. And we also did a study on pressurization of our cement. So we designed a tool for pressurization of our cement into the glenoid bone, and you will have a very good cement mantle around your component if you do so. So I think there's not one big step you have to go to have a good result in the long term. There are several small steps to respect. And for me, it's clear. I always use a jet lavage. I always use a pressurization. Let the component harden if necessary, and just do a good job.
You've mentioned multiple times as we've been through how important the experience was that you had with Joe Walsh, and you learned from him the Latarjet and how he could do this procedure in 25 minutes and it was always perfect. And you've obviously published his long-term results, which are quite good. In your own practice, I know you've shifted now to kind of a new idea, which we've both watched and we both think is fascinating. And I'm hoping you can talk to us a little bit about this new procedure. How are you doing it? What are the advantages potentially over our traditional techniques? And then what does the future hold for you in that regard?
Yeah, as you mentioned, I trained 1 year with Gilles Walsh in Lyon, France, and we did tons of Latarjets, and I would say it's really one of my favorite shoulder surgeries. So I still do most of my Latarjets in the classic open technique like Dr. Walsh has shown me, with 2 screws, very standard subscap split, not taking down the subscap, just a split. However, if you look in the results, the results of the Lyon group are perfect. They have in the 20-year following up paper, where I'm a co-author, we examined all these patients, and after 20 years, the redislocation rate, the true redislocation rate with popping out the head was 3%. So this is a number that is hard to beat. However, there are some studies, for example, from Philip Moroda, showing in CT scans after a while, the subscap reacts. So especially at the inferior portion of the subscap, there may be some atrophy, there may be some fatty infiltration, and that's logic, because what you do with a subscap split, you make a permanent split, so it will not heal. Because when you rotate, when you move your arm, the conjoint tendon is always sliding through the subscap. So it's a permanent split, and the inferior part of the subscap may be affected. And if you look for other results from groups not from France, not from Lyon, they reported, some of them, high complication rates related to implants, screws, and so on. So then the idea came up based on Laurent Lafosse with the arthroscopic Latarjet. I tried it. I was not always happy with my level of the split of the subscap. It was, in my hands, always too high. And you need this portal going through the pectoralis major muscle. You may be at risk to damage the nerve and the vessels. So then I was thinking about the technique. How can I improve it? What could be a change to do it arthroscopically without risk for the nerves and the vessels, and without splitting the subscap? So, and this was when the idea came up of the so-called flipped Latarjet. I know, Peter, you called it the triage, which is also a cool name. Maybe we have to think about it to rename. So my idea was just to go in a different way. And actually, I don't want to convince anybody to do that, because we just treated case number 8 on last Thursday. So it's just too early to convince anybody to do that. But I'm just trying it. I'm carefully selecting patients and following patients. And we will see if this is a technique that works pretty well out. So what we do is we do not prepare the undersurface of the coracoid. What I do, I prepare the superior surface of the coracoid. We have a drill guide where we come from the posterior aspect of the scapula, so we're drilling from posterior to anterior. So by drilling, there's no risk for the nerves or the vessels in the front. And after all the preparation has been done on the glenoid side, coracoid side, and so on, we make the osteotomy. And in this operation technique, you need to do it with a cerclage or with buttons. So actually, after we placed the cerclage, we prepared the bone, we made the osteotomy, then we don't go through the subscap with our bone graft, we just bring it above the subscap. So it's like a Fosbury flop in high jumping. You use the superior surface of the coracoid and you just flip it over the subscapularis muscle, tendon, and then you bring your bone graft to the anterior part of the glenoid. And it's a little bit weird at the beginning, and it's hard to follow if you watch the video, because the tip of the coracoid is now not at the inferior part of the glenoid, it is in a standing position, so it's upwards. But the nice thing is that your conjoint tendon is now running above the subscapularis, and you still respect the so-called sling effect. So it is a bone block procedure that can be done pretty easily arthroscopically. There's no risk for nerves or vessels. You have a bone graft procedure, you respect the sling effect, and you don't have to go through the subscap. So as I said, it's just the beginning. We have to work out the results. We follow our patients carefully, and I will report on the results. The surgical technique is actually under submission in arthroscopy techniques.
That's really good. And one of the building controversies is the idea of screws versus independent buttons versus bone block cerclage. I know you've looked at that and you're using the bone block cerclage. Thoughts about advantages or disadvantages of each, or is it really dealer's choice?
I mean, if you look at the studies biomechanically, we did one that was published 2 weeks ago or so. I mean, it's logic that 2 screws have the best stability in almost all of the biomechanical studies. So it's a very rigid system, but it does not mean that buttons or cerclage does not heal. I don't think so. So Pascal Boileau, for example, has shown that by using buttons you have good healing rates, and other groups as well. So with the technique I just described, it is pretty hard to use screws, but because if you want to come from the front, you have no split in your subscap, and you have the conjoint tendon in front because you flipped it over. So it's pretty difficult or almost impossible to use screws without damaging the conjoint tendon or the subscap. So this is the reason why we have to come from the back and why we have to use a cerclage. What I found in one of my first 8 cases, we had 1 failure. This was maybe related to incompliance of the patients, but maybe it was also a surgical problem, I don't know. We had a cut through of our cerclage through the 2 drill holes, and so the bone block dislocated. So I revised this patient to an classic open Latarjet, and he's doing very well. And that's the reason why we changed from the classic technique without any metal support, but to using the cerclage with a supportive, very small plate that supports the strength of the construct underneath the coracoid.
So it's a super interesting technique because it takes so many of the advantages, I think, of advances in a traditional technique, drilling from the back, moving away maybe from rigid fixation to instead the suture cerclage, which I think is, hopefully an improvement even over buttons. So I congratulate you on it, and I'm very curious to see what the results will be, and we're glad to see that you're going to follow it, and then let us know if it works.
Thanks. Don't congratulate me before it's proven that it works.
We don't mean to curse you that way, yeah.
I do want to follow up that the listeners should know that we're here in Munich on Oktoberfest week, and we have the traditional Lederhosen garb on, and it's just been an incredibly special visit for us, Patric, and thanks for bringing us.
Yeah, I like your outfit, guys.
Well, thanks again for doing this with us, and it's just been a great visit. We've enjoyed obviously everything we've learned from the operating and also the culture of Bavaria, and we look forward to seeing what you will accomplish in the future.
Thank you so much.